I am Oommen John. I am work at the George Institute for Global Health, and today we would be uh, going through the basics of human-centered design applications for intervention development. Next slide, please. So for the program today, we would be looking at the key definitions of human-centered design. What are the guiding principles of human-centered design, the specific methods, and a few examples from the field, and if time permits, a few hands-on experiences as well. Next slide, please. So in this module, we would be looking at understanding, developing pathways of understanding the human needs, which is the crux of human-centered design, and application of principles of design thinking to respond to the identified human needs, engaging stakeholders through the design process, and applying a systems approach to designing health interventions. Next, please. So we'll just go through a couple of definitions. I know many of you are particularly aware about human-centered design. Some of you have applied it in the context of your work. Yet, for some of us who have not had the opportunity to interact or apply human-centered design, here are a few definitions for understanding. So primarily, human-centered design is a creative process that starts with people and ends with innovative solutions that are tailored to meet the needs of these people that we are talking about. Human-centered design is a problem-solving approach that utilizes a series of iterative, not non-linear approaches or steps to tailor-make specific solutions for complex problems. As we know, when we're designing interventions for the health service delivery or health system strengthening, we are working in a very complex environment. And therefore, applied systems thinking and approaching it systematically to problem solving is a key component. And bringing in the human-centered approach brings in an element of critical aspects of understanding the needs of the beneficiaries and all stakeholders involved in this process. And therefore, we will be able to come up with innovative solutions, products, or services. Empathy is the core fundamental aspect that helps us to understand and share in the experience of another person and communicate this understanding clearly and articulating the expressed needs, the lived experiences, and bringing it all together. So empathy is a core part of the human-centered design. Next slide, please. Co-design is fundamentally how we go about applying human-centered design and developing innovative solutions in which the community members and all stakeholders who are part of the ecosystem are equal contributors in the design process. So here again, the lived experiences and the experiences that each stakeholder brings to the table from their perspectives is a critical element of the co-design of these innovative approaches. And prototyping is the method by which, or the application of what we have understood from the empathy mapping, understanding the human needs, and it is basically creating an experimental model of a proposed solution for testing or validating the ideas and the design assumptions. And all other aspects of its conceptualization is quickly iterated. And it is a very iterative process in the sense that you can quickly look and see what the prototype looks like, go back to the stakeholders and the people who have contributed, engage them in feedback, and look at iterating the model as quickly as possible, and particularly using optimal resources. In many of the LMIC contexts that we work in, the resources both in terms of time, getting together the stakeholders, and also the financial resources are limited, and therefore prototyping is a very useful way of ensuring that we are able to quickly iterate and validate our concepts and get the feedback that is necessary. Next slide, please. So to look at our problem statement, what are we trying to solve today? We are trying to look at how can health services utilization be improved, or how can, in the specific context, how can vaccine uptake be improved, or how can we ensure better vaccine delivery in certain constraints or in areas that are particularly difficult to reach, overcoming vaccine hesitancy. Such are some of the problems that we have at hand. We know that health services utilization is influenced by human behavior. Yet, in the design of health services, very little consideration is taken from the values, beliefs, needs, and aspirations of its end users, particularly the beneficiaries of our health services delivery, immunization services delivery, and also all stakeholders who are concerned in this, which could be community leaders, it could be community members, it could be healthcare workers, it could be decision makers, it could be the government officials, everyone. And health intervention design needs a systematic understanding of the real needs and underlying challenges that are facing the health-seeking behaviors. Next slide, please. So, in terms of the principles, we're going to kind of bucket them into two blocks. So, one is the core components of the human-centeredness of our design approach, and the other being how do we bring in the creative mindset to this whole process. And these concepts have been adapted from a very recent book called Health Design Thinking, second edition. And here at the core of the human-centered approach is empathy, co-design, and understanding the social determinants that influence behavior and decisions. And on the creative side, we have the approaches of questioning and challenging the status quo, trying to understand into what are the factors that could be responsible for certain behaviors, the way people seek health services or have the way they make decisions about why they would do something or why they wouldn't do something. And visualization is an approach by which we could put all of these concepts onto a visual map that helps us think through the various steps, something like the user journey mapping, and then using tools like prototyping, like we had mentioned before, quickly iterating the idea into a concept, into a solution, into a process map, and into a process workflow, and using storytelling. Storytelling is an extremely powerful tool to bring creativity and bringing the creative mindset into the whole process of human-centered design. Next slide, please. So let us take an example of a mother and child. And let's try and see how we can apply these principles of human-centered design to keeping in mind at the center of the universe of this whole approach, the mother and the child. We know that both the child and the mother and everyone around them, the stakeholders, the caregivers, the other people concerned in the ecosystem, have their needs as well as their desires. And in a human-centered approach, we would need to identify the needs and also elicit or outline the desires. Next slide, please. While we have the mother and the child at the core as the stakeholder, we would also need to take into consideration there are several interpersonal interactions that are going to be part of this ecosystem. Like when we talk of the mother and child, then we also need to take into consideration other core family members. For example, fathers. Quite often our immunization programs do not take into consideration the father's perspective or engage the fathers in the whole decision making or in the interactions around vaccine uptake or immunization coverage. So what about the healthcare providers? What about the people in the community? And what about the society in general? Because the values, beliefs, and perspectives from all of these influencers do have an implication of how an intervention is both designed, implemented, and for its uptakes and for its success. And so we focus both on who is changing and on how to change the context and how to enable that change that we desire through this whole process of human-centered design. Next slide, please. So how do we understand the needs and the desires? Next, please. So when we start observing as part of this human-centered process, which would be observing how a mother interacts with the child, observing how she feeds, observing how the grandmothers or the other caregivers interact. So sometimes we probably would need to go into the real life situation or to really elicit the lived experiences, maybe visit some of these mothers who are caring for their babies in the home or in care centers or even within a hospital setting or a care delivery setting. And when we observe, we make clear observation and we note down all the needs that are there. And through a process of inquiry, we would be able to elicit the desires. Next, please. And this is what we would say as through a process of conversations or through conversing, we will be able to elicit the desires. Next, please. So to ensure that we do both of these, we would need a lot of patience and care and humility at the core of it. Next, please. To observe as well as, next, please. To converse, we would need both. And in the next step, we would need to do something called the user interviews. And these user interviews builds on empathy, like we mentioned. So basically understanding where a person's needs are, where are they coming from, what are their aspirations. And we also, through these interviews, build behavioral insights. And these behavioral insights are understanding of what could be changed or what could be moved or what could be achieved. And there are several literature around how nudging of behavioral patterns can be brought into the health services delivery, particularly in the context of immunization uptake and vaccine delivery. Next, please. So for conversing and for, next, please. So this is something that has been adapted from the human-centered design approach of the UNICEF. They have an excellent resource available on the website, Human Center for Design. And so I would like to outline 5 key actions of the human-centric design process. So keeping people at the center, planning and solving with a systems view like we discussed earlier on, making the research quick, interactive, personal, and action-oriented, identifying solutions or developing solutions that really align with the workflows, the habits, and also the motivations. And sometimes we have to really think out of the box if a workflow is not really working in a certain context. For example, if people are not coming to the vaccine delivery points or the immunization clinics, we need to probably understand what are the factors that are responsible for that. And as we would see later in an example from Ethiopia, the timings of the clinics was an issue. And when they were able to understand what are the preferred timings, a solution could be built around that. So therefore, identifying solution that aligns with habits and motivations is key. And the final step being testing the solutions with the users. Again, this is in the process of the prototyping and testing, and learning and adjusting and testing again. So in the iterative process, we ideate, we develop an early prototype, test it, learn from it, and adapt, adjust, reiterate, and test again. Next slide, please. So co-design as a concept is basically a participatory approach where we bring in all possible stakeholders as active participants in the design process. And we recognize and acknowledge that each member who are part of this co-design process have deep knowledge of their own experiences. And through this collaborative process, everyone is given a voice, everyone has an opportunity to share their perspectives and their aspirations, as well as what they think might be a solution that might work for them, and what might be really the benefits that they see from the solution. So at the core of human-centered design of health interventions is the participatory approach of co-design. And this would mean that we put aside all our assumptions and presumptions and really take each stakeholder at their value. We do not question them. Why are you bringing this perspective? Or in all of our experience, all of our knowledge, this is what we practice, or this is what we believe in. So it gives a level playing field and a table on which every stakeholder has an opportunity to share their perspective and bring that knowledge and lived experience to the design process. Next slide, please. So for co-design, we can use user interviews. This could be a one-on-one interview, or it could be in the process of as part of a focus group. And photojournals are an extremely useful tool where we take snapshots of the user journey or the various interactions of a parent and a child with the health systems or the immunization delivery systems, and document the entire mapping of it through a journey map, and then use this in a brainstorming fashion, even asking all stakeholders to share their perspectives on what they think about the user journey. What are the bottlenecks? What are the process improvements that can be brought in place? And believe it or not, we would be able to gain invaluable insights into what might be blind spots for us as program implementers, program designers, that the end users and the stakeholders bring to the table through a process of co-design. So these are valuable tools, and several of them, I've just listed just a couple of them that are commonly used in the process of human-centered design. Next one, please. So broadly, going to the co-design principles or co-creation principles are, on one hand, the behavioral sciences, and on the other hand, the design thinking, and bringing them together for the human-centered approach. So we have discussed also this in the earlier on. So evidence-based insights about the universal aspects of the behavioral aspects, and behavioral insights form a key component of the human-centered design process. And design thinking is basically a swift, low cost, and iterative process of being able to think through the entire solutioning and bringing this rapidly in a participatory manner on the field in the real life setting to a specific location, and gaining actionable insights from this is bringing all of this together, as we can see in the Venn of this two circles, as a human-centered approach. Next, please. I know this is a very busy slide, but this gives an overview of the HCD process. And as you can see, there are various tools that one could use. One very commonly used is creating personas, the different kind of people who are part of the user journey as well as of the process flow, and what each of these personas interact with, and that is used to create the journey map. And these journey maps are clearly areas, potential areas of inquiry, and it serves as a discussion guide. And in terms of identifying opportunities, a rapid inquiry into using the journey map into the whole process, and synthesis of this inquiry and consolidating the insights from that, and then moving on to an idea generation and using that idea for prototyping and feeding back, and based on the feedback, incorporating that and taking that into a pilot testing and measuring on the ground how these improvements can be effected, and iterating based on the learnings from the pilot. This slide could be even taken for 2 hours, and we can delineate all of these elements over multiple steps. But in the interest of time, we will quickly move on to the examples. but this very useful resource at the UNICEF Human-Centered Design for Health website. Entire manual is available there, delineating all of these processes, the tools, and the steps concerned. So this slide kind of gives an overview of the entire process and the tools that are available for us in the human-centered design process. Next slide, please. So we will look at two examples, one from Ethiopia on immunization strengthening and other in the context of COVID from India. Next slide, please. In this example from the field, this is from Ethiopia, and this is an exercise that UNICEF had undertaken. The idea was to look at reaching zero dose and under-immunized families across vast geographies and languages and cultures, and how to apply a human-centered design response to this challenge. Next one, please. So this one of the key aspects of this exercise was to segment the entire region into different segments based on the problem statement, that is the vaccination coverage of both zero dose as well as the low coverage, and representative areas, representative from these specific target areas were selected for the human-centered design process. Next one, please. So the underlying principle was to look at the different key players or key users, stakeholders. So I know this is a very busy slide, but you can see that they have segmented it into opportunities for healthcare workers and basically to investigate how how the healthcare workers interact with these stakeholders, the mother and the child and their caregivers. And the next opportunity was around the community leaders, how these services of immunization delivery was aligning with the community's needs and its practices. And the questions that were asked was, how can we involve the community in designing a service experience that is more convenient to them, accepted to them, and that would have long-lasting impact, and how can they be part of the whole process of this designing. Next slide, please. So in the persona mapping, they had identified that the various perspectives that came from the different personas. For example, the healthcare worker said that quite often they are overwhelmed with their work, that they have very little time in their hand to go after people who are not necessarily up to date on their immunization, or specifically target the zero doses. And the father in the equation said that my responsibility is making sure that there are resources earning for the family, and it's a mother's responsibility to take care of the health needs. There was a prevailing perception in the community that you only go for immunizations or vaccines when the child is sick, and similar kind of voices from these various personas. Next slide, please. So a critical opportunity that was identified from the persona journey mapping was that there was a clear opportunity to engage the fathers, and how might the fathers be included in the whole process of decision making, as well as in the process of ensuring better uptake of vaccines, and what voice might they be able to bring? How can we engage the fathers in more interactive manners in this whole process? And again, another opportunity that was identified was a caregiver opportunity. One of the experiences shared by the caregivers that the caregivers were not really valued or were not really welcome at the health facilities or where immunization delivery was happening. So how could they be part of the process? How can we make it frictionless for the caregivers, and how can we identify the opportunities for the caregivers? Next slide, please. So here is a perspective that came from the field. Training should be given to health professionals who are providing the services. If they get this training, they would be able to solve the challenges that are coming from the community and the very different perspectives from the various stakeholders from the community. And this whole of this applied human-centered design process has been iterated, and it has been embedded into the ongoing immunization strengthening process in this particular context. Next slide, please. We would now look at an example in the context of applied human-centered design to enhance the uptake of both COVID-19 testing and vaccination. And this case study is from India, and it was done between March and July of 2021. And this was coordinated by PATH and Final Mile as the partners on the ground delivering this. Next slide, please. So in this case study, the objective was to understand the key enablers and barriers to COVID-19 testing among the target population in these identified 2 states, and understand the conscious and non-conscious drivers of vaccine hesitancy or refusal towards the COVID-19 vaccine, and identifying strategic levers for designing communication and behavioral interventions, and also the service delivery protocol for both the COVID-19 test uptake as well as improving the vaccine confidence in the target population. Next slide, please. Next slide, please. So there were multiple phases of user interviews. So this slide shows the segmenting of the beneficiaries or the personas according to the age brackets, a mix of urban and rural populations, and specific insights on barriers to testing, barriers to vaccination, what is the barriers between the first dose and the second dose, and across both the states, and the number of interviews that were undertaken and the insights from that. Next slide, please. And the understanding that was gained from these insights were tested with healthcare workers, with vaccination staff who were involved in vaccination, the informal care providers, the local governance leaders. There was liaison between the government and the community, and specific focus group discussions were undertaken to understand barriers to testing, barriers to vaccine delivery, and what was the hesitancy in going for the second dose of vaccine once they were vaccinated. Next slide, please. In terms of the insights that were gained, so what were the, these were clubbed into what were the factors or beliefs that were contributing those opposed to testing, what were the delay in testing, what were the reasons for denying the testing, and who were being indifferent to testing. So these people who were indifferent to testing viewed the testing as an unnecessary thing. And people who were opposed had a view that test was a mechanism for control, that the government was and the systems were putting unnecessary control over people and their beliefs and their freedoms. And delay in testing, the insight from that was they viewed testing as the last resort. And those who were denying testing had the opinion that tests were too expensive or they were too costly. Next slide, please. So specific interventions based on what were the system level challenges and to bring in new influences. So there was onboarding of community leaders, a health focused approach was taken, establishing testing as a medical decision and not necessarily something that is pushed by anyone else, but that it is actually participatory decision making along with the healthcare provider. And particularly the need for new influencers and the role of doctors and medical stores. Medical stores in the Indian context do give a lot of over-the-counter medications, and they were very strong influencers. So both medical professionals as well as the store recommendations were valuable in interventions that were introduced. Next one, please. So in terms of user experience, so there were tools that were designed specifically for improving the decision-making metric and improving the user journey in terms of behavioral guidelines, in terms of favorable testing narratives, and caregiver toolkits were developed. Next slide, please. On the insights on the vaccine hesitancy was that vaccines were irrelevant, vaccines are scary for me, vaccine is a scam, and vaccines is a costly alternative. These were the insights that were gained from the user-centered design workshops. Next slide, please. So the specific interventions that were designed is addressing the information gaps and specifically fighting the or overcoming the myths and the misinformations, encouraging advocacy and adherence through behavioral guidelines on vaccine experience and a customized communication approach from the field workers and for the field workers. Next slide, please. So in a nutshell, what are the three truths that we can gain from a human-centered approach for the field? So human-centered approach emphasizes skills that are reframe the relationship between design and implementation. There is no absolute agreement about what human part means and what involves different stakeholders, distinct human skills. And HCD is a flexible but disciplined approach to innovation that prioritizes people's needs and experience when designing complex systems. Next slide, please. I would skip this slide because we don't have much time. So here are some useful references. These two are invaluable references that I came across on the UNICEF Human-Centered Design for Health website. There are guiding principles, a whole whole set of illustrations and tools that can be used. And this handbook of health design thinking from Cooper Hewitt is an excellent resource as well. Thank you so much for this opportunity to share with you about human-centered design. And if you have any doubts, please feel free to contact the organizers and we can try and address those specific queries that you have. Thank you so much once again for this opportunity to share this with you. I thank Gavi, UNICEF, CDC, and WHO for giving me this opportunity to bring this to you. Apologize for the technical challenges and hope you enjoy this course. Thank you.